Next up, we've got Professor May Krishnasamy. Yeah, thank you. May is a Professor of Cancer Nursing at the University of Melbourne and an Honorary Professor of Cancer Nursing at the Peter Mac Cancer Centre. She is a research and education lead for nursing at the Victorian Comprehensive Care Centre and a deputy chair of the Cancer Research Advisory Committee. She's a past president of the Clinical Oncology. Stop. There's an awesome amount here. Her research focuses on cancer supportive care and health equity and experiences of patients with poor prognosis. So we've got the pleasure of 2 presentations, one pre-morning tea and one after. So this is the Transforming Pancreatic Cancer Care through Nurse-Led and Consumer Co-Design Services, all the way from Australia. Welcome.
I am for those of you who know me, I'm quite capable of talking non-stop for about 3 hours. So I just thought I'd check whether you needed me to stop. Let's put this up. Thank you very, very much for the invitation to be here. It's a real privilege and I'm delighted to have time with you today and really looking forward to having conversations with many of you. So I'm absolutely thrilled to be here. I've got my other glasses in case I can't read what I've got happening down there. But in a way, the talk I'm giving after morning tea would probably have segued well with Jason's talk, but what a remarkable presentation and a real sort of privilege to be following Jason's talk. And I think for me, one of the first things I wanted to say is how on earth can equity not be cool? Right? You know, so Jason's like, it's not cool at the moment. How on earth can it not be cool? And I think that Martin Luther King quote that he finished with is absolutely timeless and is probably more relevant to us now in the world that we live in than it was even when he spoke it in 1967. So I want to talk about a piece of work that I've been lucky enough to be driving with patients and carers and multidisciplinary clinicians in Melbourne. But I've scribbled some stuff down as Jason was talking. So I did update this talk last night and then very cleverly managed not to save it to the USB. So I'm going to ad lib as I go and jump back and forth. So please forgive me. But there's some things that I'll come to that Jason talked about. So he talked about issues of availability, affordability and acceptability and try and weave those into some of this conversation. But really want to sort of start by resituating this talk into those 3 steps to inequity that he talked about. So issues of social determinants of health, and I'll talk a bit more about that after morning tea. But those issues of access to care, and not just access in terms of getting into diagnosis, but access then around how do you continue to have the care that you need? We'll talk about the needs piece. But then also that assumption that when you get to care, it is of equal quality to what somebody else is having. So I'm going to try and pull those in. And really sort of looking at this issue around pancreatic cancer, and I'll talk a little bit about why pancreatic cancer. But again, pulling in that stuff that Jason talked about, needs-based, and that all of us in this room would know that not all needs are equal. And yet that's how our system is set up. It is set up with an assumption that we all need the same thing. And I think as nurses, 52% of the global nursing workforce, that's what we are, of the global health workforce. We have a capacity to drive the conversation that all needs are not equal. And actually, if we want to shift that, you better engage with your nurses. So coming from Melbourne and Australia, I want to acknowledge the traditional custodians of the land on where I work at the University of Melbourne. I work on the lands of the Wurundjeri people of the Kulin Nation. And I pay my respects to the elders past, present and emerging and recognise the privilege, excuse me, I should put my water. Privilege that my colleagues and I have of working on these unceded lands that always were and always will be the lands of the First Nations people of Australia. So I'm going to skip that one. So I want to talk and come slightly to Jason's point about why some of these cancers are problematic and why I'm interested in pancreatic cancer. And that came from obviously years of clinical nursing. My dad died of pancreatic cancer. and with a daughter who, granted, was the other side of the world, but was diagnosed and dead in 10 days, and was cared for in a small community hospital. He was diagnosed on Christmas Eve, and this young doctor rang me in Melbourne. He said, "Oh, I don't know what it is, Ma." He said, "But he's not right." He said, "You know, we'll get him back in the spring for some chemotherapy." And I went, "Okay, what's going on?" He said, "We've just drained 17 litres off his abdomen." And I said, "Well, it's liver or pancreas." And he said, "Oh, we think it's pancreas with liver mets." I said, "But he's going to be dead in a fortnight." And this young doctor said to me, "Well, I'm not telling him that." And I said, "No, please don't tell him that." So even in a country where we have the NHS, which granted is slightly on its knees, but, there is this sense that this was a professor of literature. He was an eloquent man. He had health service knowledge in his family. And yet, even for Dad, the reality had been, had I not been there to say, he wants to go home, he wants to die at home, his main concern is pain, I want a syringe driver, I want enough morphine for an elephant, all that sort of stuff, that actually he would have died in hospital with a conversation about chemotherapy that was never going to happen, or even worse, might have happened. And so, even for those of us who are affluent and fortunate, these things are not equal. So this is an outcome slide of pancreatic cancer outcomes. So average sort of 5-year survival for most cancers is 71%. And this data is the same all over the world. For pancreatic cancer, it's anything between 10 to 13%, depending on where you live across the world. So in Australia, it's the 8th most common cancer. It is the 4th most common cause of cancer death. And as Jason has told us, there's so much hidden and lost in that data, right? So who's dying? Where are they dying? Why are they dying? Why are they being diagnosed late? That's all hidden in there, but I'll come back to some of that. Here in New Zealand, it has been the 10th most common cancer, 5th most common cause of death. It is shifting. But again, as Jason has told us, in terms of outcomes, you can see here all-cause mortality of all cancers is around that 70%, but you can see what's happening with pancreatic cancer mortality rates here. And they haven't changed in 30 years. And they're slightly better, but nothing really. And the only reason they're better is because we are, for some groups of the population, getting people to surgery at an earlier stage, but it's a tiny proportion of people. So this is a really problematic cancer from a biological sense. But this is the issue for us in this conversation today, isn't it, about actually what else is happening for people. And we know that here for Maori people, for Australia with First Nations people, Canada with the Inuit people, wherever you look in the world where there are First Nations peoples, their outcomes are poorer, considerably poorer. But it's also poorer if you live regionally, rurally, if you have to travel for surgery, if you don't happen to have specialist cancer nurses popping up around the corner, if you don't have people who can chaperone you through the system and you fall out through the system. There's something called the leaky pipe of healthcare systems. So even if you can get people in, how do you keep them in the system? Some of the conversations that Jason was having around having to travel for treatment, people may choose and opt not to come for treatment. And we see this every day as nurses because they can't afford to put petrol in the car, because they have to make the decision between, do I feed my family or fill my script? So there are huge inequities in the system that are around ethnicity, rurality. Lord help you if you have a mental health issue as well on top of all of that. If you're poor, all of these things that compound people's outcomes long before they're diagnosed and long before they hit the system. And I'll come back to the question of, so what do we do about it? So for us, as a team of people, we're largely nurses, but we also have a really strong team. I'm very lucky I have a team of 20 consumers who work with me around all of the studies that we do. And they tell me very quickly if they think I'm off the mark and I'm just, off on an academic flight to fancy, and tell me pretty quickly if they think it's a waste of time. But we'd had an opportunity to do some work with people with pancreatic cancer. And what came through from those conversations very clearly was the inequity, the real sort of lottery of whether you were going to have access to a specialist cancer nurse. And I'll talk a bit more about this on the next slide. but how important that is and the data around that, and what we need to do as a cancer nursing specialist professional group around gathering data on our impact and our outcomes. So we set up 2 studies, the first of which was funded by the Victoria Integrated Cancer Services, which was about the development of a specialist nurse-led model of telehealth care for Victorians affected by pancreatic cancer. Now, this was driven by consumers. It was a question largely from people who lived not just regionally and rurally, but also in outer metropolitan areas, who were saying, well, how do I get a specialist pancreatic cancer nurse? We haven't got one of those in our hospital. We haven't got one of those in our community. We were just talking at the table at the Piramac. We have 32 nurse consultants. We're a tiny hospital. We have 6 inpatient wards, and one of those is subacute short stay ward. We are tiny. We have a very large outpatient population and a very large outpatient clinic, but we have 32 nurse consultants who are tumor stream specific. We have 6 nurses in our upper GI service. 1 is dedicated just to pancreatic care. So, you know, we're not all needs are equal, right? So, but what we wanted to do was respond to those challenges from patients and nurses and doctors and allied health people in the system going, well, that's all very well for the people who get a Piramac, but what about everybody else? And so I'll talk a bit about these studies. And then the second study, we were lucky enough to get a very large grant from the Medical Research Futures Fund, which is a big nationally competitive body, to actually take the model of care that we designed in the first study, co-designed with patients, family members, healthcare professionals, and are now testing it in a multi-site randomized control trial. So what pushed us to do this? I'm going to have to turn around because that's no way I'm going to be able to read that on the screen there. So what we know from international evidence is if you have a specialist cancer nurse involved in your care, this is largely data from lung cancer, but it's also from, there's some data from colorectal, breast, and some coming through on some hematological cancers. If you have a specialist nurse involved in your care, not only do you have better experience of care, you have better health outcomes. And I don't just mean you have less toxicities. Your duration of survival is longer. Now, we would all know why that is. It's because you're there to catch people as they're in that leaky pipe. When they're about to fall into the system, they can't keep coming back. So actually, that language that we assume is around medics, doctors keep people alive, we need to start reframing that. We keep people alive. Because if you can't keep people in the system to come for the clever medicine and treatments that have cost us billions, by the way, but we still let people fall at the leaky pipe, you know, actually people will not have the health outcomes that they are entitled to. And if you are poor, regional, rural, First Nations, have mental health issue, are socially isolated, Lord forbid you get older, you will not do as well. I had a great quote the other day that says, actually, aging is living. So for those of us going, oh God, I'm getting old, it's actually that sense of, well, what's the alternative? And it's not attractive. So let's be grateful we're getting old. Anyway, so we also know from big trials that if you have nurses who have cancer knowledge and skill involved in your care, that you have less symptom issues, you have less depression, less anxiety, less mitigable toxicities. Toxicities are going to happen, but it's those ones that can be prevented. We know that telehealth is acceptable to people. As nurses, we love to be face-to-face with people. But what our patients and our carers are telling us is actually they really enjoy a conversation at home sitting in their PJs with a cup of tea. Because it means they don't have to put petrol in the car, they don't have to take a day off work, they don't have to pay somebody else to look after the children or whatever it may be. So actually models of care that have served us well because they make us feel great, because people are in the room telling us how wonderful they are and how nice it is to see us, actually are not serving many of our patients well. We know in Australia, as it is here, as it is in many, many countries, that access to people like yourselves is really ad hoc, and that's unfair. That's a social injustice, that some person with pancreatic cancer or whatever has access to somebody like one of you, and a person living 4 streets away doesn't. That's not okay. And this is especially true for those patients who live regionally, rurally, and remotely, where there are so many barriers that we're all aware of to getting to treatment. So I'm going to move a bit faster through this. So in Australia, it's like with you here, but it's similar from some of the documents I've seen. There's a real focus on care at home, closer to home. You know, people want to be close to home. Well, not if the quality of care is not equitable. And how many of our patients would say, actually, I'd rather travel the 8 hours to get to see the specialist than have care closer to home and be cared for by somebody who sees somebody with pancreatic cancer once every 5 years. Right. So there are complex issues here to deal with. Many patients, certainly in regional and rural Australia, if they're having care closer to home, have less likelihood of access to people like yourselves. We are losing nurses quicker from the workforce than we can manage. So how do we make sure that each one of you is where we need you to be, seeing the people that we need you to see? We will be, 123,000 nurses short in Australia, 9 million nurses short globally by 2030. So we have to use you as a scarce social justice resource. Who do the top of the tree people in this room need to be caring for? Who do the generalist cancer nurses need to be caring for? And how do we make sure that our generalist cancer nurses have the support, knowledge and skills that they need and access to that subspecialist knowledge that every one of us needs to be able to keep on top of our game so we can deliver the best to our patients? So the approach, therefore, to addressing equity and what was behind our thinking with our study is that we need to build models of care that don't need more of us, but allow us to work in a way, okay, there may be need for more of us, but actually in the reality that we have now, when getting more is not likely, how do we make sure that you're enabled to work in models of care that make sure, one, you're not exhausted, burnt out and leave, number one priority, because if that happens, that's a disaster for our patients, disaster for our health system, disaster for our societies, but also means that we have the greatest reach to our patients. So I'm going to move through. So this is the first study. We had come from the conversations from a study called Pan Support, where we built a specialist online supportive care resource with and for people with pancreatic cancer. We talked to families and said, what would a great model look like? What would it look like to you? What would you want in it? What would you want nurses to be doing, and how would you want us to deliver it? And so in the first phase, we had these workshops. We had patients and carers, 10 patients and carers. We had 20 multidisciplinary healthcare professionals. We had great fun in the workshops. We had sticky papers. We had whiteboards. We had you name it, but people putting up priorities, moving them around, sort of just telling us. And the primacy of the voice was with the consumers and the patients. And then we asked them to tell us how that model should look, what should be in it, when it should run, how often people should have access to it. And then once we had that agreed, we went on to phase 2, which was then actually putting that model into practice in one regional cancer centre, a place called Bendigo in regional Victoria, to see actually, can you do it? Does it work? Before we go on to a trial. I'll talk to this quickly, but these are the kinds of outputs that we had from the workshops. So we had the consumer perspectives, you can see here at the bottom, and the healthcare professional perspectives. So we had the workshop separately first, consumers and patients, and then healthcare professionals, which is that King's Fund methodology that was referenced on the previous slide. So you manage the power expectations. You put patients and carers in a room with very senior doctors, they'll assume that the doctors know best for them. Often, not always, but often. And so you have them independent conversations first, and then you bring everybody together where everybody's voice has equal power. So we took this back to the joint workshops and said, okay, this is what you were all saying. So for the patients, they were saying, we want scheduled follow-up calls. I want to know somebody's going to call me once a week. I don't want to have to guess or think, oh, shall I call? Is it worth calling about? Is this important enough? Is this a problem? I want somebody to call me. I want questions that are important to me, what matters to me, answered on symptom management. And I want to know that there's a structure around those questions so that if I forget to say something, I'll be prompted by the nurse to ask those questions. I want information on what I can do to self-advocate. I want information on what I can do to keep myself well. All things we know that are important for people. I want to be signposted to services and resources that I can access to help me keep myself or my husband, wife, son, daughter as well as possible for as long as possible. I want to know that this nurse can triage me to ED, and I'll talk a bit more about that in a moment, or can triage me back to my medical team, and all those other things that you can see there. I want somebody who can identify the gaps, somebody who can go, we need to do something now before this gets worse. The docs, nurses, and allied health colleagues were saying almost exactly the same. We want somebody who can pick problems up quickly, refer people to services, get them back into the system if we need them back in the system, that they can get to ED quickly if that's what they need to do. But we want it documented. We don't want something happening to our patients where we're not aware what's happening. We want this person, this model to be part of the system. And so for us, when we set this up, and as we go into the trial, the nurses in this centralised telehealth model, they sit at Peter Mac. It's not a Peter Mac model, but they sit at Peter Mac because it gives them a clinical context. But actually, they have an honorary appointment with each of the hospitals that we're linked to, so that when the nurse is giving advice about the patient, they can see into the medical record. They can see whether somebody's on a trial, when they last saw the doctor, what language is being used, what's happening, and feed that back to people. So you can see what these consumers, these patients and carers were telling us. This is the stuff that they wanted. And they wanted the care to be available to patients and the family members when they needed it, as they needed it. So the other piece around proactive calls out from the nurse, and I'll talk a bit about the nurse now, or nurses, was also that patients and family members could call in as well. So if there was something troubling them in between those weekly calls, they could call. So we had a long conversations with patients and carers about the nurse. Who should this nurse be? What should this nurse be bringing? And they said they have to know their stuff. And if they don't know their stuff, they have to know who to refer to. So the nurses we've got working on in this model of care at the moment have expertise in pancreatic cancer. They have expertise in telehealth care. They have expertise in clinical trials that came through luck, we weren't necessarily looking for that. And they have experience of working in research. They understand the importance of data collection. So, somebody really skilled to the top of their game. But what the patients were saying was, this person has to know what they're talking about. So the impetus for us here is the opportunity through these kinds of models is demonstrating beyond our patients, but to their family members, to the communities, actually, we do know our stuff. And actually, when you engage with a nurse who knows their stuff, they keep you alive longer and they keep your quality of life better. They keep your care cheaper for the healthcare system and they manage your financial toxicity. These are things we need to be collecting data about and screaming from the rooftops. So I'll move through these because I've talked a bit longer than I wanted to. So we had that model worked out with patients and carers, and they said, right, does it work? So we thought, well, we won't go straight to a randomized control trial. We better see whether there are problems in the system. So we worked with Bendigo Health and the cancer centre there. They are fantastic. They're a really engaged group of people who service a large region, rural area as the main sort of regional cancer centre, and they have been just the absolute best to work with. So what we wanted to know was, is this model going to be acceptable? Is it going to be appropriate? Is it going to be practical? All those things, so availability, affordability, and acceptability that Jason talked about. We wanted to make sure that this was going to be that. So, the acceptability, does it feel right to people? Does this work for people instinctively? Can you do it in practice in the context of busy sort of care? Can you do it in practice? And then fidelity. Can we actually develop this model in a way in which people said that they wanted it to work? So we've got a mixed method study. We collected interviews, data, survey data, medical record data. And I'll skip through this, but essentially what happens is the patient is told by the healthcare team, we have this model of telehealth care. Would you be interested in finding out more about it? We only wanted 12 to 15 patients just to see. This was just ironing out glitches and making sure that the model worked. We had 12 people sign up straight away. Oh, yes, please, access to a specialist pancreatic cancer nurse. I'll have a bit of that. And then people complete a weekly, just an 8-item PROMS, a patient-reported outcome measure, specifically developed for people with pancreatic cancer. So tapping into their main problems. But of course, they can tell us anything else. The nurse then phones them once a week, and they can either send the PROMS data in before the meeting, or if they don't want to fill it out themselves, the nurse will do it at the beginning of the call and then focuses the consultation around that. And then we have what's called clinical management pathways, which I'll show you. So these were developed by 50 multidisciplinary healthcare professionals about what do you do for pain, what do you do for nausea, all those problems that people with pancreatic cancer have. We have 13 of these that are evidence informed so that the nurse in the clinic can respond with a confidence of the system that he or she has evidence-based informed care. The docs allied health staff are all happy with this. And so then Lisa, who's one of the lead nurses, will look at this and go, okay, these are the questions. This is what I've done. Standardized care. You can collect data. You can start showing benefit. And then she types that in as she's going through the conversation with people. We have this all online. It kicks out something called a clinician report that says, I spoke with Mr. Jones. These were the problems he was talking about. This is what I've done. I've made a referral to palliative care, psychology, dietitian, whatever it may be. Or if those services exist in the hospital, she would refer those back, or he would refer those back to the team saying, can you make a referral to whatever it needs to be? And so again, all documented straight back into the medical record. The nurses have visibility only. They can't write in the medical record, but they can send these back into the medical record. So it's a closed loop system, which the patient said was really important to them. So what did we learn from that? We had all patients who were approached. There were 10 in the end. We had 12 sign up. 2 unfortunately died before they could come into the study that quickly. 9 patients, 7 carers completed. The intervention goes for 12 weeks. They said it had to be brief. And as one gentleman said, you know, love, he said, I might not be here in 15 weeks, so let's make it 12. You know, they've just been amazing people to work with. They were able to complete the proms. They were happy with it. They loved the phone calls. They all took part. They didn't miss any of the nursing calls. In fact, we had quite a lot of calls in between. We had lots of referrals made by the nurses out to external services, back to GPs, palliative care groups, and internally. The clinicians really liked it. They said, actually, it takes a lot of pressure off us. We don't have to worry about whether we need to follow up. We know you'll get back to us. It's taken a burden off our care. And this is the piece I love. The patients are saying, this has been a lifeline. I don't know what I would have done without this service. And every single person who's involved wants to carry on beyond the 12 weeks of the intervention. So we're now, even though they're off study, we're still continuing with the weekly phone calls. We're not collecting data because we don't have ethics to do that. But they're still calling Lisa and the team. We call out to them, and we still keep in touch with the healthcare system. And really quickly, in the last couple of minutes, I just want to talk to you about the next piece that we've gone on from there. So this is the piece about transforming healthcare. This is not rocket science. Each and every one of you will be doing elements of what I've just talked about every day. It's how do we structure these in a way that when we measure them, we can say, that was the nursing sensitive piece that made that difference. Because often we do things as part of multidisciplinary teams, which is very important, of course. We're not lone rangers. But the problem is when we do that, it is really hard to point our finger and go, that was the nursing bit. And so when government goes, why have you got all these nurses? There's lots of them. Let's get rid of some of them. They're an easy target. And we go, oh, no, but we're really good. And we make a big difference. But then they say, oh, really? Where's the data? But we're hidden. We're hidden in a complex system. But once you start structuring it and you co-design the system with patients, then you start having a language about what is nurse sensitive here. I can call, they respond, they engage with the system. This is what they did about my pain, my nausea. It's all documented and it's all recorded. But what we need to do then was say, actually then, can we prove that kind of model of care, which you could do with people with liver cancer, stomach cancer, renal cancers, these small groups where you can't have specialist nurses everywhere. So what happens if you took the expertise in this room and made 5 of you one of these hubs for liver or stomach, and you've got national reach? You're still connecting locally, so people stay at home, but you centralize the expertise. Now, you could be based anywhere, of course. Centralization often assumes that you're in a specialist cancer centre. Why? Bendigo are really keen to have the next regional hub, so they will service the whole of regional Victoria. Don't need Flim and Peter Mac. Because the other thing that's happened, of course, with the model is we're upskilling fantastic generalist cancer nurses in Bendigo Health. They're having conversations with Lisa and the crew, so they develop their specialism around caring for people with pancreatic cancer. So there are different things we can do. So the trial is, can we actually overcome this inequity of access to specialist pancreatic cancer nurses? And what difference does it make? So we've got this multi-site randomized controlled trial. We've got 8 centres across Australia. And we're particularly looking at, because you also have to play the game, right? What is the language that works for funders? So we're looking at pain and symptom management. We know that we do so much more than that, but it gives us something tangible to measure and to demonstrate our benefit. won't talk about all of this. The primary objective is, can we prove effectiveness? Does this make a difference to people's pain and their symptom management? Does it reduce financial toxicity? Does it improve well-being of patients and carers? Does it reduce distress? So these are secondary outcomes. Does it actually impact healthcare resource use? Do people end up less in ED? Do they have less unplanned presentations? Now, often ED visits are wholly appropriate. So sometimes you'll see nursing trials going, we're going to reduce ED visits. Now, not if they need to be there. And if you happen to be collecting data at a point in time and you happen to have a cohort of patients who all genuinely need to turn up for ED, the risk is that you show that what you're doing is not effective, but actually it's wholly appropriate that these people have turned up. So be careful when we think about it. Never say that we're going to be cheaper, because often our care is of equivocal cost or is of the same cost, because often our interactions are longer, our interventions are longer. That's where we make a difference. That's where we're different to our medical colleagues. That's our point of difference. We spend more time with people. So we're not necessarily cheaper, but we might have a better equity use of the resources that we have. So just coming to an end, we've done the work, we've had conversations with patients, they've helped us co-design a model of, that will transform how we deliver care to people who currently don't have access to pancreatic cancer nurses. We can do it with fewer nurses, with greater reach. We can help our colleagues in the system by taking some of the burden of them. But most importantly, we can make a difference to the experience of people, finding those people who currently don't have the same opportunity for care from people like yourselves. So there's every indication from our data early on that suggests that the intervention is acceptable, it is feasible, and it can be delivered as intended. So those things that Jason was talking about, it can target availability of care, affordability of care, because people don't have to leave their homes, and it's acceptable to people, beyond acceptable to people, both patients, carers, and the healthcare system. The patients and the carers that we worked with valued the intervention. They want to keep going with it. Once they've got that connection with those nurses, they're not letting it go. And now Lisa's transitioning a lot of people into end-of-life care and really being there right up until the end and the point of reference for people. It's great for our colleagues in the system who've got a bazillion patients to try and see if the people in front of them, let alone thinking what's happening to people once they've gone home. And it actually offers us a way of having a cost-efficient model that has reach, that has scope, and that has impact. And really importantly, in the context of the conversation today about advanced practice, allows nurses to work to their full scope of practice, demonstrating what happens when you unleash the power of cancer nurses. We will transform the healthcare system, but we need to do it in ways we're collecting data, and we'll talk a bit more about that after lunch. So next, we're just getting to the end of the ethics and the governance processes with the 8 centres. We'll start recruiting patients end of this year, early next year, and then we'll be data collecting for the trial in 2026, and then we'll be publishing it. And we're about to start a similar study with people with young onset colorectal cancer, and that's a whole other conversation. Thank you very much.
Does anybody have any questions? Yeah. No, that's great. Thank you very much. I think it's important to note that full scope of practice for nurses. I think we spend a lot of our times thinking that we're advancing out of our scope when actually our scope is just getting bigger and bigger. So thank you for supporting us. That's awesome. So we've got morning tea now. The doors are open. The food is out there. Just before you go, just want to get your attention to the back of the room. We've got a couple of slides up on the wall that were poster submissions from other team members around the country, and also our lovely sponsors. So we've got MSD at the back of the room, AstraZeneca and Roche, and without your guys' support and generous contributions to our conference, we wouldn't be able to do this without you guys. So they are very friendly. Please talk to them. And if you guys can come back about 10:40, we will keep going. Enjoy.
All right, I think we'll get going again. My apologies. Just gonna look at that. Always want to do that. I'm doing that. There are people at the back, I think, who talk even more than I do. So I'm going to start again. I'm sorry for being slow in getting going. I've been enjoying conversations with people. Just give people a second to take their seats. Okay, so following on from Jason's talk and some of the points I was making earlier and some of the great conversations I've been enjoying with people, this is a sort of bit of a whistle-stop tour of a piece of work that we've been working on for quite a long time, and I'll tell you a bit about that, to develop what we initially called a checklist that we thought was about trying to work out with cancer nurses, what is it that makes a person with a cancer diagnosis complex to care for? So that's where we came from. So, but I won't do the acknowledgement again, but Jason's really talked to this, but I just want to bring back some of the stuff that Jason said, just to sort of put into context and remind ourselves of some of the things he talked about. So he said patients are different, and I'll talk about that in the context of what we've been trying to do. So remembering that the patients are different. Barriers to timely access and diagnosis is critical in terms of equitable outcomes to care. And people who present with comorbid disease are much less likely to have optimal health outcomes. Things we know, but they are things that we, on the whole, are not good at recording and then taking account of when we plan and deliver care to people. So I just wanted to sort of start by that sort of patients are different. And I was scribbling down when Jason talking, but how do we capture this? How do we show the contribution of nurses through capturing data so that we can inform the system when people are different? Because it's the people who are most different are the ones often who have the greatest capacity to benefit from the care that you provide. Right, so people like me who will walk into, Lord forbid, walk into a cancer centre and go, nobody's asked me about my supportive care needs. I need some holistic needs assessment, please. And so I'll be fine, right? Because I can navigate the system. I can ring the head of cancer surgery and go, Sandy, can you fit me in tomorrow, please? Right? So I'm there. But the question for us is, how do we capture data in the context of this talk that allows us to inform the system to show what happens when you have cancer nurses picking up those patients who are different, not the easy ones, who can advocate, who will get the care, who will get the trials, who will have the mobile number of the specialist nurse to call day or night, or the head of surgery, or whoever it may be. So how do we get the data to advocate for those patients that Jason talked about and all the other patients that we know about, regional, rural, isolated, those people talked about? How do we get the data to advocate for those patients? Because moving the dial forward for the likes of me and us is not equity. In fact, what it does is it actually creates more inequity, because I get better and better and better care, and the people who don't have the same opportunity to do that fall further and further and further behind. And more of the resources go to this. Now, just while I'm blathering on about stuff, patient-reported outcomes. Now, some of you, may be familiar with this. There's a growing international evidence publication based on, it's all about patient-reported outcome measures. We've all got to have PROMs in the system, and we've all got to collect PROMs. And we've got to use PROMs to build new models of care and know where we need to put the money. Who do you think is not in that PROMs data set? It's all the people that Jason talked about. It's the people with health literacy issues, preferred language, not English, regional and rural, socio-demographically disadvantaged. They're not in the PROMs databases. So if we build our health systems and our models of care on the amazing PROMs, assuming, of course, that you have 50 people sitting in the background just waiting for the PROMs data to come in so you can look at it and feed it back to the team straight away, because otherwise what you're doing is having PROMs data coming into the system that nobody has the capacity to respond to or look at, and that's unethical. So it's just when people talk to you about PROMs, there are two reasons for PROMs. One, collecting data for big data sets, which is fine. You don't need somebody looking at that straight away. But those data sets will be deficient in the people that we're concerned about. Or you have PROMs data to inform practice, right? So real-time response, like we did in the pancreas work. But if you haven't got the capacity to look at that data in real time, what you're doing is you're asking patients to tell you what's wrong with them, and then there's no visibility on that data. So always be, of course they have a place, of course they do, and they standardize measurement and they do give us databases, but really important to remember that. So people are different, and PROMS data is no different to that. And so when you think about the articulation of PROMS data to AI, algorithms, predictive capability, so we keep building our system on white, affluent, middle class, health literate people. So anyway, enough about that. Makes me twitch. Okay, right. So the thing that Jason was talking about, we need data to advocate for patients. And the quote he put up was, different resourcing is needed in order that different groups enjoy equitable health outcomes. So the question for us is, how do we do that as nurses? So I've left that up there long enough, so I'm going to move forward. So this is an amazing group of people, apart from Holly, who refuses to have a photo taken. So Holly's there. So Holly, Amelia, Sancha, Carla, and Liz. So these are my colleagues who've been working with me on this piece of work for 12 years, maybe. But Sancha's a nurse, Liz is a nurse, Niels is an epidemiologist, Carla's the most amazing healthcare statistician, unbelievable, looks at any set of data and goes, where are the patients in this? Amazing. And Holly is a new PhD epidemiologist who's a rising star, and I must link her with Jason. Anyway, so what we were really sort of exercised about a good decade ago was that, we know that every person who interacts with the health system interacts with the nurse, every single patient. So how do we mobilize our potential? Every interaction between a nurse and a patient and the whānau is an opportunity to address inequity, that we actively, unapologetically look for inequity in every patient that comes into our care. Nursing's contribution to and role in addressing inequity is overlooked. The biggest health workforce, and we are overlooked. It is deemed to be the business of amazing people like Jason, thankfully, but actually, where's the translational capability? How do we have the benefit of somebody like Jason enable us to actually do something in practice? There are over 20 million of us worldwide. So why can we not be used to our advantage, our skill and capability to address this stuff? So we started back before 2010, but this was the first sort of real study. It was funded with $3,000 from the Cancer Nurses Society of Australia. It's been a labour of love. And we set out to ask 100 cancer nurses across Australia, what makes a person with cancer complex to care for? And when we'd got through things like multiple appointments and car parking, and we said, no. Those are system issues. What is it about the people that makes you think when you look at somebody, this person's going to have complex care needs? And I'll talk about both in a moment. Qualitative data, lots of focus groups. And what came out after we analysed all that data was a really rough draft of a checklist. What would be the things that you would think, oh, yeah, it's going to be that, and that. And then we sent the draft checklist back to the people, the 100 nurses, about 5 or 6 times. We kept changing it. They kept sending us feedback and through surveys, and we recorded all of that. And then we were able to move on. I'll talk a bit more about this. Don't worry about not seeing this for the moment. I'll talk a bit more about that. We then, once we had the final draft, and it literally took us about 15 drafts, we sent it out to 50 cancer nurses across Australia and gave them 3 hypothetical case studies of 3 patients. It said, can you test the checklist with these patients? Does it make sense? How long does it take you to complete? Does it seem to work? We had items taken out, we had new ones put in, we had some reworded. And then once we got to the end of that process, we had 10 nurses at Piramac work with real patients, 5 each. So we had 50, we had tested it with 50 people to see whether, one, was it easy for the nurses to use in the context of a real-time interaction with people? What were the patients' reactions to it? What did they think about having these questions asked to them? And what we heard was everybody liked it. It took a couple of minutes to complete, although the conversation that goes with it, of course, takes longer. But the actual checklist took a couple of minutes. But what we had done initially was we'd given every one of these items a score. And then the patient said, well, if I have a score of 15 and he has a score of 2, but his 2 is more damaging than my score of 15, what does that mean? And we went, nasty. So we just dropped the score and thought we're going to leave that. So because actually to do that well, you'd need hundreds, if not thousands of patients, and then do some psychometric testing and look at predictive capability. And Carla could have done all of that for us. But actually, we thought, actually, does it matter? Does it matter what score somebody has? Because then the risk is you start making decisions about who gets care based on a score. It's like quality of life. I've got a quality of life of 60. What's yours? You know, meaningless. So we dropped the scoring and decided that if people have one item on here and it's a potential risk for them in terms of their ability to have the best care possible, that's enough. So what we learned through from looking at the data, listening to patients, talking to the nurses, is that the complexity checklist, as we've been calling it, was not so much about complex care needs. It was actually about social determinants of health. There was some medical stuff in there, but it was largely about social determinants of health. So that, not the proximal stuff that Jason talked about, although there are obviously medical things in there, not the obesity and the diabetes, although they're there. It was poverty, rurality, insecure housing, homelessness, all the things here. What early childhood development issues, nutrition, access to food, all those things that were enormous. And so we sat there and went, really, is this the business of nurses? And what can we do about all of that? And we said, well, we can't fix it. But if we turn a blind eye to it, it doesn't matter how clever our immunotherapy drugs are going to be. These people are not going to do well. So how do we know about them? How do we find them? How do we give them a visibility, a voice, a data set in the system that allows us from the first time they come into the system to go, these people are going to need more. So that issue of different resourcing, these people are going to need more, whether it's more information, different kinds of information, more referrals, contact more often, whatever it may be. But we know from a social justice point of view, if we overlook these people, they may have curable cancers, but they may die because they just won't be able to come back for treatment or whatever it is, or they won't know how to take the medicines. So, we said, well, actually, how important is it? How important is it to address these social determinants? Now, there are loads of studies. This is data reported by the WHO. 30 to 55% of health outcomes are determined by